Thank you, Arvind. Thank you for the kind invitation. And I don't know who's the giant, myself or Ram preceding me. But it's true, we always have a competition as to who actually copied from whom to pass the exams and how we got to this stage. This is where I come from Huddersfield, up in the north of England, for those of you who may not know. The iconic cricket pitches, which may be more attractive to you, are Old Trafford and Headingley, and that's in between there is where I come from. I have no disclosures related to this talk. Total knee replacement today is a well-accepted management protocol for end-stage OA. We've seen good long-term results. Most of the issues have been addressed. And overall, we seem to have a better understanding of knee replacement as a whole. As a result, indications have widened. Younger, more active patients are being offered the procedure. And we expect about 3 million to be done by 2030. But the problem we do face is only 80% of these patients feel satisfied after the procedure. For a long time, total knee replacement was considered a perk of retirement, but this has been disproved by several long-term survivals, patient demands, and more younger patients are being offered the same. Technology has moved on. We very rarely see the ambassador car on the streets of India today. The Jaguar seems to have replaced it. We've moved on from the DC-3 to the 787 and from the megaphone telephone to a smartwatch. The same has happened in orthopedics as well, particularly in total knee replacement. We've moved from the GoBot instruments and the condylar resurfacings to proper ceramic total knees. In effect, we've kind of moved from the T-Series to the Ford Focus, designed for living, engineered to last. But just like the Ford Focus is not kind of enjoyed by all, not all our patients remain satisfied. Today's demands of total knee replacement are very variable, from wanting to sit cross-legged for religious and social purposes, or to be able to tie your own shoelaces. Total knee replacement needs to give you that satisfaction. And therefore, the challenges as an orthopedic surgeon to who provide total knee replacement surgery is to improve functional outcomes by accommodating higher flexion, prosthetic longevity, but more importantly, patient satisfaction. So what are the future frontiers in our aim to provide a successful total knee replacement? And they encompass a number of things, including orthopedics to digital health, artificial intelligence, and we heard a lot about that in the last speech. So the newer frontiers looks like this: patient-specific instrumentation, different materials, robotic surgery, and the works. And I'll try in the next few minutes to try and go through a few of these. So let's start with the designs itself. Designs of total knee replacements have evolved. We've moved a lot from the J-shaped curve to today the graduated curve. And I'm sure as we learn more and more about the native knee, that will keep on changing. But it often makes you wonder, is this just a gimmick? Is this just industry-driven? Or do we really understand the knee much better now? The debate as far as fixed or mobile will continue. This talk about metal sensitivity, and yesterday we had a very good discussion on that. Is it really a problem, or is it just a myth? Is it just something that we need to actually deal with? Or the whole process is commercial marketing? What about bearing surfaces? Materials do make a change. Thus far, we've actually stood with stainless steel and titanium. We've now got ceramic and alumina or oxidized zirconia available in the market. But are these really good enough? If you look at ceramic, the 5-year results are pretty similar to what is at the present time cobalt chrome on polyethylene. But the question of allergy has been introduced. The lab wear results are better, but we don't know what the long-term results are. The same with oxidized zirconium, or the 10-year results are exactly the same. It is claimed by the company that 30 years is what the knee is going to last. But will that knee replacement actually see that? Or are we going to develop some more metal which will actually make knee replacement better? The common factor of failure is polyethylene, and we know that 2 to 21% of failures are responsible. Polyethylene is responsible for that. We've seen a decrease in recent times because of improved polyethylene by cross-linking, better sterilization, and the role of antioxidants. However, these haven't been there for long enough for us to really say that the new polyethylene is different and is going to make a difference. We seem to relate it to the hip, but the hip and the knee are two completely different joints. And when we look at polyethylene wear with respect to ceramic, whether it's fixed bearing or mobile bearing, there seems to be a 7 times better wear rate as far as ceramic on polyethylene is concerned. And perhaps that's where we need to look. So the ideal polyethylene would be strong, oxidatively stable, good fatigue strength, and low wear rate. Do we have that, or is this something that we need to get for the future? But what is really changing as far as total knee replacement is concerned is the technology in orthopedics. We've moved from the conventional surgery, we went into navigation, and the robots now are beginning to come, probably in a big way. Let's look at navigation. The computer-assisted knee surgery came in. It told us that critical alignment was very important. It saved money, probably because of less revision in the future. Was it a fad? Was it industry-driven? Certainly in the West, it seems to have died a little bit. It was state-of-the-art 5 years back. In India, it's still in use, very much so. However, in the West, particularly presently in the UK, in 2012, 3.8% of total knee replacements were navigated. In the present NGR, it was difficult to actually find how many of them were navigated. That poses a question, is it necessary? Was it just a marketing tool? Has it died? Not really. It seems to be making a mini revival again. And that mini revival, or the entire process of navigation, has probably given us something which is very important, and that is patient-specific instrumentation. It is less invasive. There is less operative time once you get grips with it, but there are costs involved and a preoperative CT or an MRI scan. Robotic surgery seems to be coming in a big way. It is kind of one step ahead, one giant step ahead from navigation. It ensures accurate placement, alignment, rotation, coverage, sizing, contact points. But is that going to really improve patient satisfaction? And one needs to wait and see whether that is actually going to change. We've just heard about artificial intelligence. Artificial intelligence is going to revolutionize healthcare. It started to do so in other areas, and in surgery, it is taking off in a big way. It is, after all, a collection of technology to help machines do its job. I understand about karma and sanjog and jog, but I think it's here to stay. It improves quality, cost and access, and presently already in use as far as computer-assisted surgery is concerned. And presently, the projected budget for this is $6.6 billion by 2021. 3D printing is probably the way forward. We all have to accept that the variable individual anatomy, the additive technology of 3D printing almost helps us to make the prototypes which is specific for the patient. This allows accurate anatomical representation and a near anatomical fit as far as total knee replacements are concerned, which would be so much different from the standard sizes that we have on the shelf, the standard sizes that we need to use, and the adjustments that we need to make to the bone for them to fit. Probably a better fitting implant would result in better function and patient satisfaction. We already have that in place with Conformis. And you can see on your left-hand side, there's a very different type of knee replacement, one that has been prepared after 3D printing. Even the joint line on the medial side and the lateral side is different, which makes it very important. But what we don't know as yet, how good it is. The early result seems to be reasonably good. The one area that it certainly is better is because of the customized fit, the amount of overhang and the residual pain that the patient may have. What is also important to understand is 40% of men do not fit to standard knee replacements. 68% of women cannot use standard knee replacements. Shape drives function. There's optimal bone preservation, and reducing the sizing of components invariably results in some sort of adjustment. Digital health is here to stay. The digital revolution, along with healthcare, tracks what the patient is up to, manages the patient, improves healthcare provision, and actually personalizes healthcare for the patient. The future is bioprinting of synthetic cartilage and probably preventing osteoarthritis and therefore leading to total knee replacement to actually develop. And researchers at Sahlgrenska Academy have even managed to multiply and differentiate these cells to form chondrocytes in the printed form. And this may actually be the real way forward. They've even managed to produce menisci in sheep. In the future, if you do a meniscectomy, probably 3D printing through an MRI will be able to replace that. TKR in the future, I can see a patient appearing with knee pain, arrives with a 3D print of his knee, expects you to build a prototype in your back lab. You then actually implant the implant, probably a ceramic on crossing poly. You provide him with the post-op instructions on a smartwatch. You have a virtual follow-up. You never see him in the clinic. He comes on your iPhone or an Apple Watch and tells you what he is up to. One only hopes that he will eventually digitally transfer your fees as well. Otherwise, we will be without a job. Thank you very much.